My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening and welcome to Lectures of Distinction Series 2. My name is Manish Bhatia. Tonight's session is on ankle fusion versus ankle replacement, the great debate, and the talk will be given by Mr. Rick Brown. Thank you very much to our sponsors for Lectures of Distinction, Ramsay Healthcare. For those of you who have joined, in a very warm welcome once again, and please submit your questions via the Q&A link, which will be on the bottom of your screen. And just a reminder about the feedback. So the feedback will be, the link will be there again in the chat. There will be also a QR code at the end of the session. And there will be various links, and you will also receive an automated email. So once you have submitted your feedback, you will get your CPD certificate. Introducing tonight's speaker, Mr. Rick Brown, who is a consultant foot and ankle surgeon at Oxford, and he established the foot and ankle services at Cheltenham. And he moved on to Oxford in 2016. He's also an honorary senior lecturer in the University of Oxford. He is the current chair of the EdCom and has a great interest in education and training the next crop of orthopedic surgeons. So his passion for teaching is really admirable, and I'm looking forward to tonight's talk by Rick. So without taking any further time, over to you, Rick.
Thank you very much, Manish, for the kind introduction, and I look forward to trying to advance the topic a little further. It's a second part of a two-part series. Last week was the first part with my colleague and friend, Steve Heppel, who taught us about early ankle arthritis, and this should follow on with the more advanced cases. So I just want to share my screen properly. Can you see that? Yeah.
Yes, we can.
Yep.
Yeah.
Right. So we'll talk about what to do when ankle arthritis gets more severe, and that very quickly brings us on to the great debate and hot topic at the moment about what to do between an ankle fusion and an ankle replacement. So we'll talk about revise some of the comments and topics from last week. We'll talk about how to assess a more severe ankle. Then we'll talk about treatment options, both non-operative. You must always remember to try and optimize the care with the easiest techniques for your patients. And then we'll talk about surgical treatments. And I mean, in particular, we'll spend most of the time talking about ankle arthroplasty and ankle fusion. There'll be time for questions, as Manish said, so please send your questions in on the chat. And then we've got some registrars from around all four corners of the United Kingdom to take questions of cases on this topic. So last week, we talked about why the ankle joint is specific and different from hips and knees. It's where ankle arthritis is usually post-traumatic, it's rarely primary. And the key reason why it's so important if there's a traumatic injury is you disrupt the congruency and the contact area changes, leading to arthritic changes. And it's also believed that the actual chondrocytes and the quality of the cartilage are different in the ankle compared to the other joints. The important thing is to have a look at the workload out there. There's a large workload of ankle arthritis. And if you think about our colleagues in hips and knees, they dominate, but we have a very large 29,000 cases of symptomatic severe ankle arthritis referred to the UK orthopaedic team each year. Vast majority is post-traumatic, 70%, and then you have rheumatoid arthritis and some of the other causes, rare things like avascular necrosis. But if you remember, post-traumatic and rheumatoid, that's the majority of them that lead on to the severe changes. The assessment, all these things will come out in the cases we discuss, but it's important to look at the other areas of other joints involved, what are other comorbidities, are they smoking, especially if you're going to contemplate a fusion operation, and really, what is the patient's expectations? What is their function? What do they want to achieve from their operation? And that's so crucial when it comes to deciding between an ankle fusion and an ankle replacement. We're really getting to the stage where we probably think, and we'll talk about this in detail, that the outcomes can be similar. They're overlapping for these two treatments. So you need to tailor your choice for the specific patient. And then when you're taking a history, you always want to find out what other treatments have previously been tried. In your examination, it's important to confirm the source is indeed the ankle. So the subtalar joint, the talar navicular joint, common mistakes, and the severe arthritis, the talar navicular joint, everything's a little bit stiff. You may be focused in on X-ray changes that are moderate in the ankle, but miss the fact that the talar navicular joint is the main cause of the pain. You want to be looking at alignment. That's how you could look at the patients here, how they're walking. And of course, a neurovascular examination, absolute key to every clinical examination, and the soft tissues. We can't do a complex operation involving an ankle replacement if the soft tissues are all scarred or there's a history of previous infection. And the two key things is that arthritis of the ankle is often, because it's traumatic, often a multiplanar problem. So it's not just a coronal plane problem, varus and valgus, but there's also rotation. There's also neighboring joints that can be deformed. So you may have supination that's fixed or pronation that's fixed in the midfoot. And therefore, when you're in the examination, the key thing to remember once you've examined the hindfoot is look at the midfoot for correctability. It's a multiplanar deformity. You have to think in multiple planes to get the right solution. Imaging. In advanced arthritis, X-rays are key. They're always weight bearing. Lower alignment views are important because if you're going to fuse the ankle, then you want to make sure you're providing a patient with plantar foot to the floor. And that's important if they've got arthritis in the ipsilateral joints above. So if the hip, it's not that important because it's a multi-axial joint, but particularly in the knee, if that patient's likely to need a knee replacement and an ankle operation, then you must make sure the alignment of the knee is corrected first, or you anticipate the correction of the knee when you go ahead to do your ankle fusion or replacement. Stress radiographs, if one of the reasons this has happened is because of a ligament injury, then you need to test the strength of the ligaments and correctability, especially if you're contemplating ankle replacement. If the ligaments are too lax, then in my practice, that means I would be loath and very unlikely to do ankle replacement. Then we have advanced imaging modalities, CTs and MRIs. But why we look at the X-rays, it's to look really in detail at bone stock, the quality of the bone. Has there been some lysis? Are there big cysts around? Is that going to change whether your ankle replacement will sit down carefully? So the quality of the bone, and you might need your advanced imaging for that. Here you can see a big cyst that if you were to place an ankle replacement, then there's a risk of a tibial subsidence. Then previous surgery, have they had metalwork, and have they had the metalwork removed? Was the metalwork infected at the time? If there's been a history of infection, even many decades ago, you'd be very loath to go and try an ankle replacement. That's probably a strong contraindication. So what's the previous surgery? Did it go smoothly? Was there infection? And this business about correction potential. Is the deformity in the ankle joint? Is the deformity in primary deformity in the metaphysis, or actually has there been some erosion and secondary deformity in the metaphysis? All of these things need to be corrected if you're doing an ankle replacement, and they may be too extreme to do that, and therefore you should fall back to an ankle fusion. Always, the most important reason why I arrange advanced imaging is to see if the neighboring joints are involved. So this is an X-ray of a patient who's got, the X-rays show that the joints, the midfoot joints have been involved. But this is a patient who's had a fusion, but you can see how the CT is very useful to see whether neighboring joints have got some arthritis in the subtalar joint. So the main reason for doing advanced imaging in our Oxford team is whenever we are concerned that the neighboring joints may have some subtle early degeneration. How to treat the patients with severe arthritis? Clearly, you should be recommending the same things as when they were less severe. Activity, try and get them to weight loss. Footwear, shock absorbance is important. Bracing is important. Steel injections are very important, not just for therapy, but also to narrow down which joint is causing the trouble. But the difference between this and Steve's lecture, there's very little role for physiotherapy in late stage arthritis. So we've optimized all that. We've decided the pain is severe. We're going to look at which procedure to do. So between the fusion on one side and the replacement on the other. We won't talk too much on how to do them, but the majority of fusions these days are done arthroscopically. In the TARVA trial, 60% of the patients were arthroscopic. There may be a little bit more in the whole general population, because the TARVA trial just was in a limited number of centres like Oxford and London, and et cetera. Still, some ankle fusions are done using frames, but that's predominantly for people who have infection and bone loss. So that's a acceptable way of doing it. Patients often are concerned about whether they're going to have any function at all. They're going to walk like a pirate with a very stiff foot, and that's just not the case. If you watch this video, hopefully, you'll see.
So I walk all the way down. This is the post-ankle fusion at 12 weeks on the right lower extremity.
So this guy's had a fusion on the right, and it's really difficult to see from his gait which side's been affected. So really good result. And here's another example of a very good result. I'll just move this on a little bit. You can see this is a patient who has had a fusion. So that's the tibio-talar joint is fused, but you can see that the subtalar joint and the foot and ankle complex still has lots of plantar flexion and dorsiflexion. So bearing in mind, once you have a good arthrodesis, good fusion, they can still have very good movement. We get patients back to cycling, swimming, golf, skiing. What you can't get them back to really after a fusion is the sports that involve a lot of dorsiflexions and movement. So perhaps yoga, that type of thing, or impact activities such as more vigorous squash, for example. Total ankle replacement. If we have such a good operation called a fusion, why do we need to even bother about ankle replacements? Well, probably that's because when you solidify the ankle, the neighboring joints have increased load, and over time they start to wear out. And that was shown in a big series from Iowa now about 10-15 years ago, which published their 10-year results. So these are from patients 25 years ago. And they showed that within 7 years, 70% of patients were starting to show wear and tear in the neighboring joints. And there's some debate about whether if you have an ankle replacement, that actually might produce you closer to normal gait and kinematics, and therefore help the patient maintain protection of the other joints. So probably you were doing ankle replacements for a little bit of extra movement and probably to preserve the other joints. The advantages, there are lots, they're slowly being adopted. The numbers are increasing through the last 10 years. Most recently, we're between 800 and 900 ankle placements a year, which is tiny compared to the numbers of hip and knee replacements. So if you have to tell your patients what the survivorship is, you wouldn't go too far wrong by saying about 85% of ankle replacements will last 10 years. But the key thing to tell them is that about 3% fail per year, need to be revised, and tell the patients that your friends who had knee replacements and hip replacements will be better off and have longer survivorship than after an ankle replacement. And the number of surgeons performing ankle replacements has slowly increased. And I draw your attention particularly to this very small number here. So it's 2017 and 18. The average surgeons are only doing 5 to 6 of these per year, which is really not very many, which is why we're trying to structure our care for advanced ankle arthritis into networks where patients would be seen by a surgeon who may or may not do a replacement, but could be referred into a network where the debate whether to do a fusion or replacement can be discussed between experts, and then the patient can travel to the person who's performing these procedures most regularly. And that's a two-way street. For the more complex fusions, patients also need to travel if they've got deformities around the neighboring joints. So what can go wrong? Well, when an ankle replacement goes wrong, it can go very badly wrong. And infection is always our biggest enemy. And osteolysis is another big enemy. You can see the big cyst here underneath the talar component, the talus can start to sink into that. However, we're starting to get wise, and we have indications to graft these, and we tend to graft them when they're progressive and getting larger, or if they're at a position of a stress riser. So if it's very close to the crucial angle gossain, for example, and you might find that if you're in that area, that the cyst might be vulnerable to fracture, then we'll be more keen to intervene. Other problems are implant loosening. This is subsidence. You can see in this X-ray that the talar component is sunk into the tibia. Heterotopic ossification can occur. You can see some ossification here. And with loosening probably comes polywear, and that is a vicious circle. The other thing you have to watch out for is the neighboring joints slowly deforming and slowly developing degeneration nearby. So what to do if these fail? When you're deciding with a patient whether to go for an ankle replacement or a fusion, what are you going to do next? What's your second operation? What's your bailout? And if an ankle replacement fails, then you're in difficult weather. You can revise, rarely people revise ankle replacements to another ankle replacement. You can do that. They're now stem prosthesis, but the majority of times we'll revise these to fusions, and the outcome from a revision fusion is worse than from a primary fusion. So if you think you're going to have an ankle replacement that's not going to do well, then I'd advise you at the beginning to choose to do an ankle fusion. Here is an example of this. Is that you can see the talar component has sunk, and you can see the lysis underneath it, and it's been stabilized by a tibio-talocalcaneal nail with a much less good outcome than if the patient had a tibio-talar fusion previously. So the big debate, which patients should go which way? So for an ankle replacement, you want a patient who's older. You want a patient who wants moderate activity. So that's somebody who might want to do a little bit of hill walking, gentle walking around town, perhaps at the very most a bit of very static tennis, not leaping around. Those are the top end of the extremes for an ankle replacement. There should be probably a reason why they want the extra movement. So perhaps they do bowls or they do some yoga, and that's key to them. If the patient has arthritis in neighboring joints, so maybe what used to be a phrase of two joint disease, so for ankle and a subtalar joint, but also rheumatoid arthritis, there's usually damage to multiple joints. So those are multiple joints in a group. The group of patients that in my practice really can't have an ankle replacement, or previous infection, poor skin, and the totally unreliable patient. So you have to those are the contraindications. You cannot have those to have an ankle replacement. The type of patient who would be best for a fusion is a younger patient. Often, therefore, they have a higher demand. They want to do impact activities. They don't mind. They already have if they already have a stiff ankle, then there's not much to lose. If they have a severe deformity, then that's a reason to stay placed safe. You can correct some deformity, and in my hands, I would limit the deformity to 15 degrees of varus and valgus, which is based on the original paper from COVID in Denmark from the STAR, the Scandinavian Total Ankle Replacement. So 15 degrees either side is a cautious criteria, which I would use. Others are more adventurous. You need to have, in other patients for fusions, are the contraindications. So if they've got poor skin, poor reliability, and they've had previous infection. Advantages, we like to think that they can preserve movement, is perhaps better function ankle replacements, but you have to get through wound healing. Then you may need subsequent procedures. Lysis, we've gone through a list of reasons why they may have ongoing pain, and that might lead to needing future surgery after an ankle replacement. So probably an ankle replacement is first operation, and they will be requiring a second one. But this is also the catch. A fusion is also an operation, it's a first operation that's likely to need a second one. And that's because the neighboring joints around the actual fused ankle are likely to progress to OA in years or decades to come. We just don't know when and which. This is the point about severe deformity. So 15 degrees in either direction, varus or valgus, I go to fusing. And then we have had some studies that have tried to go head to head. The Canadian Foot and Ankle Society have a database, and that's ongoing, and it seems to show at the moment comparable results from fusion and replacement. But there are more reoperations and replacements, but they can be as little as, well, relatively little as a medial malleolus fracture or a poly exchange, which are not great big things to get through. The Swedish ankle registry is also very good, and they have within their cohort patients who've had one of each. And the patients report equal satisfaction function between their replaced side and their fused side at midterms. That's between 8 and 12 years. And just to be absolutely cutting edge and current, not even a week ago, the 23rd of September, the TARVA study results were published at AOFAS. And this is what they showed, really. This is a prospective randomized controlled trial. It recruited and finished recruiting in 2018. Lots of centres around the UK, including some from us, were put into this. There were 144 fusions, matched 138 ankle replacements. 43% had adjacent joint degeneration on MRI before we even started. So that compares to the Iowa group, which talked about 70% at 7 years. So actually, if you go looking for it, there's probably more joint degeneration in the neighbouring joints than you'd think. At 6 months, total ankle replacement was doing better on the Manchester-Oxford score. At 12 months, which is just hot off the press, both had they caught up, they're both equal. And there's an interesting subset analysis because there are different types of ankle replacements, and one called the fixed bearing ankle replacement seems to be doing actually better than the ankle fusion group. So that's going to keep on going. And that's only at 2 years, because the really crucial thing about the debate for ankle fusion versus ankle replacement is the long term. As I said before, these patients may all, if they live long enough, need to have a second operation. Because this is my view, is coming towards a summary. It's a long game, and patients, whether it be hip or knee or ankle procedure, you're looking for one big operation procedure for their life. And in total ankle replacements, my patients certainly find it easier in the first year, but then somewhere between 2 and 5 years, they have fractures, a bit of subsidence, a bit of grumbling pain, a bit of heterotropic ossification. Whereas during the same time, the fusion patients have a worse first year because they're stiff, they're in plaster. But then the next 5 years, they're happiest, definitely happier, because they don't have all these problems because you've fused the moving parts. The ankle replacements, as you get on from 10 years, I've been doing this now for 17 years, 3% become loose per year, so they're starting to need revisions, and often the revisions to fusions, they don't do so well. But then in the fusion group at 10 to 15 years, they're starting to really have symptomatic secondary joint degeneration and having problems in that area. So those may need another second operation for that reason. So the fusion patients start being caught up. And what we really don't know is when we get out to 20 years of ankle replacements, what will they be doing? And that's really what we hope the TARVA trial is going to help us to get to the bottom of, to look at the longer term and compare the longer term with the severe degeneration that occurs in the other joints after a fusion. So this is a summary slide of the lecture part of this evening session. So the patients I would suggest in this great debate to go forward and towards an ankle replacement of the older patient, moderate activity, patients who have still some remaining useful movement. They have arthritis, whether it be inflammatory or post-traumatic degenerative arthritis in neighboring joints. And if they have mild hindfoot malalignment, maybe that's reason to correct that and do an ankle replacement, because the malalignment may have also already started to damage other joints. Patients who should not have an ankle replacement are those who had previous infection or poor skin, or patients who just cannot trust. Sadly to say, I would say one category of those, the classic comment is farmers. Farmers often get arthritis of the ankle, and farmers never retire, and farmers will never slow down. So that just being a farmer for me is a contraindication to an ankle replacement. Patients who I would push towards fusion are the younger patient. So I've fused 12, 13, 14-year-olds, 20-year-olds after infection. Those patients got a long way to go. They want to get back to high demand activities. Patients who already have a very stiff ankle, so there's really no benefit. Patients with a major deformity, and in my hands, I would argue 15 degrees in either direction. I would certainly go towards fusing if the other joints are looking pristine clinically and on MRI. And then the other patients for fusion are the ones who've got really a lack of bone stock, perhaps avascular necrosis of the talus, patients who've got poor tissues who are not reliable, and patients who've had infection. So this would be my sort of summary slide as a take home as my answer to the current debate about whether to fuse or to perform a total ankle replacement in severe ankle arthritis. So I think we've got some time for some questions, Manish, I hope. Is that right?
Very good talk, Rick. I think it gives the principles, the how to choose patients for operations, and yeah, that does it. We have one question has just appeared from the audience, and the question is, what's your strategy or experience of replacing an ankle which has previously been fused?
So I have not done that. I know Ian Winston had a small series about 7 or 8 years ago. So at the moment, I haven't done that. I have on my list for a few weeks to come is a patient who's had an ankle fusion that's non-union of an ankle fusion. So this is still trying to move despite someone's very best efforts to get it to fuse. And I think actually what I'll go in there is it's a mechanical non-union. They've got some bone metabolism issues. It's not infection, and therefore I think it's safe to take that all apart, make the cuts, and try and put an ankle replacement in to provide a little bit of movement because it's trying to keep moving. The reason I don't really see a great reason to do an ankle replacement that's solidly fused before is these people often coped with a very stiff hindfoot, and it's a major undertaking to go crossing over the divide.
I absolutely agree with you. I think it would be very hard for me to again convince a patient to have a replacement after solid fusion or good fusion. I have a few questions for you, if you don't mind, Rick.
Yeah, please.
So you did give the contraindications for ankle replacements. In your book, is there any absolute contraindication or relative contraindication for fusion?
I think the patients who I immediately look at and say, I'm going to do an ankle replacement, they still don't have a contraindication. I could still do a fusion, but I just think they're going to do better with an ankle replacement. So I'd find it hard to think of a patient I just couldn't get out of trouble with a fusion. But when I see a patient who's got rheumatoid arthritis with multiple joints involved, and you know they're all going to be painful at some point, those are the ones I would think first of an ankle replacement.
Sure. No, absolutely. I agree. Do you have any concerns? So if you're fusing an ankle, in the group you alluded to earlier, people who have some sort of immunocompromise, either they are long-term smokers or diabetics, are you worried doing fusion in them? I mean, how do you, what do you talk about non-union in that particular group? Do you extend the period of immobilization, etc.? So what's your strategy for that group?
So we have currently a very good pre-operative assessment clinic. It's like everybody else around the country, it's probably a bit overworked at the moment trying to catch up from COVID, but we see them in that. And then if there's two different groups, so the diabetic type patient or the patient who is borderline vitamin D deficient, the diabetes, I'll tell them that they will be in a cast for longer. The vitamin D deficient ones will make sure they're taking supplements, and that they will likely fuse, they just may take longer. The patient who are sort of smokers, I read them the Riot Act and tell them to go away again, because they don't want to invest a year of their life doing an operation that's going to do badly when they could come back having changed that part of their lifestyle and have a much better chance of an operation that does well. So yeah. I push them away, but at the end of the day, when they come back again 6 months later, I will probably succumb. They will tell you they're not smoker and they'll stop like 2 days beforehand. I don't know, do you measure the urinary cotinine? Because that's the thing I'd like to be able to measure, the metabolite from nicotine to find out whether the patient is actually telling us the truth or are they lying. But urinary cotinine is the way to find out.
Yeah, no, absolutely. I don't do it in my practice, but yeah, that's the way to find out. So we have few more questions appeared from the audience, Rick. Okay. So now one person has actually given us a clinical picture. They've thanked you for a very informative lecture, and they've asked that if a patient is diabetic, 50 years old, high BMI, and has coronal plane deformity of 20 degrees varus, post-traumatic arthritis, but otherwise good skin vascularity, good health, would you consider them for replacement or fusion?
So that to me is an easy one. That's a fusion, because they're too heavy and they're too deformed. And they can go away and change the weight, but that's going to be very difficult when they've got an arthritic, painful joint. But the deformity is what would worry me about 20 degrees. So I'd fuse it.
Me too. Another question. Would you always advise adapting footwear and having a rocker after fusion? So anything after you're fused, would you ask them to change their footwear or anything?
Having a rocker sole is very helpful. Most patients don't actually need that, I find. But if a patient is struggling and they're having, or if they have midfoot arthritis, and that's the reason they're going to go on to struggle, those ones we would send to add a little rocker. Yeah.
Okay, thank you. We have a couple of more questions. Regarding arthroscopic fusion, somebody has asked, you do it anterior or posterior approach?
Anterior approach for ankle fusion. Posterior approach, I've done both. For subtalar, I've done both anterior and posterior for the subtalar fusion, but for ankle, it's always anterior.
Yeah, I think in the literature, and I was looking, the majority, 95% are all anterior. I think Nick Van Dyke's group is the only one which I could find they do posterior ankle fusions.
Yeah, you're right. He has published that.
Yeah.
You get used to doing things from the anterior scope. But that does highlight an interesting area. When do you, even if there's someone who's a scoper, when do you decide that you want to do an open fusion? And for me, it used to be when the deformity is too great, about 15 degrees. But actually, as you get better at it, you just forget that correct threshold, and you clear the gutters more, and you can bring the deformity around and correct it. So probably the absolute essence of when to do an open fusion is when you've had a large amount of bone loss into the tibial plafond, because then you have to shave away a lot of the good bone arthroscopically, which takes ages, or if they've got very, very stiff, very arthritic gutters, and then that's too difficult to clear arthroscopically. but increase very, and the other ones that I worry about are the ones that have got those massive osteophytes. So there, I will tell the patient I'm planning to do arthroscopically, put them in the traction, and quite often they will just open up, but have pre-consented the patient that he may end up having an open fusion.
Perfect. Now, Rick, there are lots of questions appearing, which is good, very good sign, but I believe you've got some interesting cases for case-based discussion. So I would like you get on with that, and then perhaps after your CBDs, we'll catch up again for a few minutes with more questions.
Yeah, well, we'll look forward to more questions on the floor, but so we have a panel of willing registrars from around the four corners of the United Kingdom. So let's try and move on to some cases. Right, let's and can you see that?
Yes, we can. Yeah.
Okay, so can I welcome Alex from Oxford, our own trainee. Hi, Alex. Thank you for coming along. So this is this X-ray on the side of the screen is a 38-year-old butcher. So he's a manual worker, and he has got had an injury years ago to his ankle. He's been chivied along in clinic with injections and arthroscopy over the last 7 years. How are you going to decide when it's time to proceed to a severe operation? How are you going to start to assess the severity of his pain?
Yeah, so obviously you need to take a good detailed history from the patient, find out, first of all, how it's been limiting him in what sort of practical ways in his day-to-day life, both in terms of work, family, expectations, nighttime sleeping, those sort of practical, and whether it's getting worse or it's been fairly stable. I've been looking at his medical history, what sort of pain relief is he taking, so what are his conservative measures? Is he doing something as simple as taking analgesia? It's quite common to hear patients not wanting to take tablets. I want to know about his social history as well, about what things that might risk any sort of large operation. So I want to know about smoking, alcohol, other medical comorbidities. Obviously this is traumatic, so has he had any other significant trauma to the joints above and below? That'd be quite relevant. And then obviously there's radiographical features, so we've got an X-ray in front of us, so looking at the extent of arthritis, different levels, and looking at sort of patient-related outcome scores and seeing how that would help guide us to help inform the patient about what his chances are of a good outcome from various different operation options.
And you mentioned patient-related outcome scores. Do you know some examples?
So SF36 would be one of the sort of classic ones, and then there's the ankle osteoarthritis score. There's a Canadian, the Canadian foot and ankle score. I think there's another word in it. I can't remember what it is. And then in your presentation earlier, there was the Manchester Oxford score.
Yep, I'm glad you mentioned the last one, seeing you've just joined our team. But
yeah.
Good. So this X-ray, you can see the cardinal features of osteoarthritis affecting the ankle joint. What do you think about his neighbouring joints? Because that's important, isn't it, when you're deciding what to do?
Yeah, so we've only got the ankle as opposed to the to a foot view as well. But so within that, as far as I can tell, it looks like the subtalar joint looks pretty reasonable, on the talar navicular joint, I can't see any large osteophytes sticking out the top that would leap out at me as particularly worrying. But obviously the tibiotalar joint stands out. Can't see the knee, so I'd want to have a view of that.
Okay, yeah, you can always have an X-ray of the knee. And so we're thinking from this that's just the ankle joint. What imaging would you do if you weren't so sure?
Well, I think MRI scan is certainly within our unit with our go-to.
So it might be just become a routine, I think, as MRIs become more and more available, that people are just checking, especially the TARVA reporting 43% of patients actually had signs of early arthritis in the neighbouring joints. So how are you going to decide in your mind which way to go for this guy who stands on his feet all day? What about his function and things? What questions would you like to know?
Yeah, so so assuming everything else being equal and his sort of foot was already sitting under his knee, I think the conversation that would be had with him is about what does he want to do and what's his expectation. So if he's just got pain, he wants to be up on his feet all day. What are his aspirations? We could talk to him about.
He wants to play football with his young son, and that he wants to take over his son's football team and be out there running every Saturday and Sunday, jumping around. So that's his answer to your question about his expectation is. So what would be which way would you call it?
Well, I think so. My first rules, I think I'd probably just have to dampen his expectations, because I would probably suggest him there is an operation that can give him that goal, given he has an arthritic ankle at this age, which is unfortunate, but that's where he is. You know, we can then discuss with him the option of, as you say, fusion or ankle replacement. I think both will result in him needing a second operation in his future. But given that he wants to be able to engage with his young child, he wants to be on his feet all day, I would suggest that fusion will give him the best opportunity to have a pain-free ankle that he'll be happier with and can engage more, but he won't be able to run, he won't be able to play football. He'll have to think of other activities.
With the fusion, people can do gentle running, but then they are basically using up their subtalar cartilage, aren't they, slowly and steadily. So you have that sensible discussion. Like you said, you have a discussion about what he wants to do. And it would alarm me if he wanted to go leaping around in an ankle replacement. So I would push him towards a fusion. So that's what he had indeed. There's an ankle fusion, and he's kept his job. He's now kicking around the ball. So he's kicking around the ball with his kids. He's not, and he's cycling with the family, but he's not really leaping around in the I don't know, the under 10 football team anymore. But it's key to assess his level of function, and you can go to a fusion, particularly if it's isolated disease. Well, thank you very much. So the next, can I call on Mark from Belfast? Let's see, are you there, Mark?
Hi, Mr. Brown, thank you.
Excellent. And okay, so this next patient is again traumatic, and he has 54, and he's got severe pain, and he clearly, you can see he's had a distal tibial fracture. How would you go about firstly interpreting those x-rays, and then how would you go about planning your operation?
Yeah, so
and then we're going to get to, obviously the question is which operation we're going to get to next.
With an AP and a lateral radiograph of an ankle, you can see, as you sort of alluded to there, there's a apex posterior deformity on the left ankle, or in the lateral view of the left ankle, as well as metalwork present within the ankle joint. He's had a complex injury to his ankle, both to his tibia and fibula in the past. We're keen to know how long that's been, and if there have been any complications to that operation in the past as well.
That's important, isn't it? If he had this even 10 years ago and he had terrible episodes of infection, that's going to change him up. But he says no, there wasn't any infection. It all healed very nicely, but he's noticed his legs a bit crooked.
Absolutely. So we've no clinical picture of him, but as I said, there's an apex posterior deformity and probably slight valgus in the supramalleolar area, distal third of his tibia. So I think it would be important in this case to look at floor to core and get some long leg alignment views.
Yeah, that's a very, very important point you've brought up, Mark. So here we've got an alignment view of his leg, because the injury he also had a femoral fracture at some point as well. So we're trying to assess his mechanical axis. What is the mechanical axis?
Basically the entry of his nail is piriform fossa down to his knee joint, and then from his lateral side of his medial tibial plateau down the axis of his tibia to the center of his ankle. Again, you've brought up an interesting point there with a femoral fracture above it, and there could be leg length discrepancy as well as the slight coronal malalignment that we've already seen at the ankle.
Yeah, and leg length discrepancies, it's interesting always to think that there's the longer leg, whichever way around it is, the injured one or the non-injured one, that's the one that's most vulnerable to ankle arthritis. Good, so we're going to do an operation, but we have to decide whether an ankle replacement or ankle fusion. But first of all, when do you have to remove the metalwork? When should you do that? In 2 stages? What would be your views on that?
Again, dictated by history, simple biochemical workup, and maybe some advanced imaging to suggest those things. Also, patient preference and the operation that you may be choosing to do. Depending on how severe his ankle arthritis is, in this case it seems to be quite severe, so you may be considering both a realignment operation and a fusion at the same time. If it was slightly less severe, you may just be considering a supramalleolar osteotomy to recorrect the ankle joint. If I was working in and around
if it was earlier moderate arthritis and he had a clear, as he has a distal tibial deformity, you may want to correct that at the core and improve things. So this guy, when you actually look at him, which you can't see a photograph of, he's got lots of scars, the skin's a bit stuck down, looks quite difficult to get good access, and it's also very stiff clinically. He's got very little movement. Which way would you go for an operation? And the great debate.
Well, considering that clinical scenario, I'd probably take the metal workout first, allow things to settle and go back. In his case, I'd certainly be looking at a fusion. I wouldn't be keen to replace his ankle.
Yeah, so a lot of scars and would be a concern, and I'd go for a fusion. Whether to take the metal work out, sometimes you can, if you're feeling confident, you can, like the red arrows, you can fire your screws past the other screws, but it's not wrong to do it in 2 stages to clear the field and come back again, and when you've got no metalwork in the way. Okay, thank you very much. Yeah. So I think Parag from Leicester, are you there this evening? Hello, hi, good.
Hi, Mr. Brown.
That your boss keeps you working very late in theatre. I'll have to have a word with him. That Mr. Batty is a bit hard taskmaster. So this is a question for you. So he has fallen off a horse. He's active. He enjoys bowls and golf. So he's got, what can you see in his X-rays? Just talk us through what you can see in his X-rays.
So he's got changes suggestive of a previous distal tibial injury, and has clearly developed quite marked post-traumatic osteoarthritis. There's almost no tibia-talar joint space superiorly. There's quite a lot of sclerosis around the joint margins. Looks like there could be anterior osteophytes as well, and some talar collapse possibly.
Yeah, certainly those osteophytes look quite challenging. It's amazing he can still keep playing bowls, because you need quite a lot of dorsiflexion for that. What about his neighbouring joints? We made a big point about the protection of the neighbouring joints. What do you think about his?
His subtalar joint does appear to show a bit of sclerosis as well, so possibly.
Yeah, so his main pain is definitely ankle, but he's got some pain clinically lateral. It's along the lateral edge of the subtalar joint, so he's pretty tender out there, and you have the discussion with him about whether to do fusion or replacement, and he is absolutely key that he wants to keep some movement. So he wants to be back out there bowling, and he's got some early degenerative change in the subtalar joint. What would be your which way would you be leaning?
It's a difficult one given his expectations. I think he would need a frank discussion about outcomes following total ankle replacement and fusion and how they best fit in with his lifestyle. He has already got degenerative changes in neighbouring joints, which we know with fusions is likely to worsen in time. So I think if he's willing to perhaps take it a bit easier with activities, you could discuss whether an ankle replacement may well reduce the worsening degenerative changes in neighbouring joints. But if he wants to maintain his activity levels, then I'd probably be discussing more of a fusion option with him.
Yeah, but his activity is bowling, so he needs to bend down and have some dorsiflexion. So that's perhaps his activities, and his expectations also push you towards what you were
ankle replacement as well.
Ankle replacement. Yeah, so he highlights the dilemma and some of the issues that we've discussed. Yeah, well done. So I mean that was him. So that's his ankle replacement in place, and hopefully that will protect his secondary joint degeneration over the years to come. Excellent, thank you very much. And then I think we're going to go to Colchester and Essex. Omar, are you there?
Hello.
Hello, hi. Thank you for coming this evening. So this is a patient who's 58. She's had a nasty fracture. Again, she's had some skin flap. In her history, she tells you she's had some post-op wound problems. And when you examine her, well, she's got deformities. How would you describe deformities really, because if you talk me through coronal deformities, sagittal deformities, how do you describe them if you're talking to me on the telephone?
So on the coronal view, I'd look at the ankle joints and the long length of the tibia as well. So
yeah, important to get the whole leg.
Proximal to distal, there are deformities in the fibula as well as the distal femur. Those are distal tibia. Regarding the ankle joint itself, you can divide it into extra-articular and intra-articular. You can talk about the talar tilt, and you can talk about the tibial articular surface angle. So those will be the angles that I would measure for deformities within the ankle joint. And then obviously the degrees of arthritis within the ankle joint. And on the sagittal view, we can also talk about whether the tibia is in recurvatum or not, and look at the subtalar joint as well, see if there's any degenerative changes there. I'd also talk about whether there's any hindfoot deformity as well. All those things I take into account when talking about deformity.
So this poor lady's got deformity in all those planes. And then what's happened to her subtalar joint?
So she's had previous fusion of her subtalar joint.
Yeah, indeed. So she would be a candidate who, well, if we're going through the list of indications, so she should have a ankle replacement because she has got a very stiff subtalar joint. But we don't want to do that because she's got complex deformities, she's got wound problems, she's got scars. So she's got she's very challenging. Which way would you go, Omar?
I would consider a fusion, and she's already had a subtalar done. So if that's the deformity in the subtalar is already corrected, then she'll only require an ankle fusion.
Yeah, and what's the problem doing ankle fusions above subtalar fusions?
Is that the outcomes are poorer than if you did.
Yeah, you're absolutely right. The union rates are lower. The same the other way around. Subtalar fusions are below ankle fusions now. Yeah, so that's what has been done. So really, she is going to have, she can't escape the stiffness and the problems, because already in that view, her Chopard joint started to look a bit thin, but she would be a terrible candidate for an ankle replacement. Good. Manish, I think that we've got through quite a few questions, but
yes. So no, very interesting case-based discussions. We've got a few more questions.
Will I come back to questions then? Okay. Well, can I thank the registrars for turning up and helping, and that was hopefully interesting and informative. Thank you.
Thank you very much, Registrar. Thank you. So a few more questions, Rick, from the audience, interesting questions. So someone has asked that if a patient wants ankle replacement and they have ligamentous laxity or instability, actually, I think they mean medial or lateral, would you do a ligament reconstruction and ankle replacement at the same time?
I would try and talk them out of it because I'm very conservative, but sometimes it would be appropriate, and then I'd do it in 2 stages. I would do the rostrum, get that tight, and then do the ankle, and that's the same if there's a deformity. Sometimes there'll be a subtalar deformity. I'll then either fuse the subtalar joint, or there might be a severe varus of valgus, and I'll do a calcaneal osteotomy and fix the ligaments, get the alignment right, and then come do the ankle replacement. And the quickest way I do that in my practice is to sort out the alignment and the ligaments, which takes about 6 weeks. The calcaneal osteotomy is going to take 3 months in plaster, come back halfway through that time, and then put the ankle replacement in 6 weeks to go. So they finish the 3 months all done and dusted, but I do in 2 stages.
Excellent. Thank you very much. Now, we have looked at the TAVA figures, and we alluded to the low numbers of replacements being done by consultants. So one of the questions is that given the low numbers and the learning curve, is it advisable that the ankle replacement are done by 2 consultants where possible?
I strongly support that, and that's BOFAS's policy as well. And we've discussed that with the NJR, and you can now enter both surgeons on the NJR, so both can have it for their logbook, both can get the experience, especially as we move towards hub and spoke systems. It's important and totally acceptable of dual surgeon operating. What's been the interesting twist of that, Manish, is that everyone wants to accredit the ankle replacement to their logbook, but what happens if that ankle replacement has a complication? People don't want to accredit that to their logbook. So yeah, you have to take the rough with the smooth.
I agree. I absolutely. It is very interesting, as you say. One of the previous questions which we couldn't cater at that time, I think it's fair we ask that. They've asked about are 2 screws enough for ankle fusion? And they've also asked your thoughts about home run screw.
So I will tend to standard do 2 screws. I'll do them from above, and they'll be parallel but in 2 different planes, and that gets compression. But if the bone stock's poor, once I've got the compression with my 2 screws, I'll put a 3rd locking screw in just to complete things. And in fact, there's no harm in a really severe Charcot type fusion to put a plate on, even as a plate as a fail-safe if you're worried about it. And we haven't talked about how to fuse with plates as another debate. Home run screw, yeah, I don't use that myself, but it can give you really good compression if you've got good cortices.
Regarding screws, whilst we are there, do you use just 2 medial screws, or you occasionally use a lateral screw as well?
That would be if I thought the bone stock. So the compression screws from the medial side.
Yeah.
And then the 3rd screw goes in from the lateral side because we're running out of space, just to lock it.
Okay. How about a varus deformity? Do you think there is any role of putting the lateral screw first to get a little bit correction of the deformity? Do you have any experience with that, Rick?
That would be my standard practice. So for varus deformity, I close the lateral side first.
Yeah.
And then the opposite way around. Of valgus, when I put to the medial side, medial one first.
Okay.
To pull it closed.
Thank you, Rick. Do you use autograft infusion if you are doing it open? So that's another question from the audience.
Probably half the time, because the reason I'll do an open one is because it's complicated with bone loss and great deformity, and I would then tend to go in through a lateral approach. And then you've got fantastic graft right in front of you, and you can pack it wherever you want to pack it and fill defects. So for the really complicated ones, I'll go laterally and use that source of bone graft.
Excellent. Yes, I do transferable approach as well. So as you said, the graft is in front of you. I think there are questions, but I'm going to, this is the last question. Somebody has asked that most candidates for ankle replacements are low demand elderly patients, and they have arthritis of other joints. So they are asking, what is the benefit of replacement in these patients? So I'm not sure. Do you have any views about that, Rick?
Well, this is the same philosophy as people having total knee replacements in arthroplasty surgery. Then they should have 1 procedure for life. So a good ankle replacement, which will protect the other arthritic joints, a low demand patient, they're going to have that operation at 75, and after over the first year or 2, then the complication rates drop off, then they shouldn't trouble you. So that would be the same as why you do a knee replacement in that older age group. It's one arthroplasty procedure for life.
That is great. I think, Rick, we are going to call it a day here, but although there are some more questions, but it has been really interesting listening to you, talking to you, having this chat about this interesting debate. Thank you so much for that, Rick.
It's been a pleasure. Thank you very much, Manish. Thank you.
Thank you. And I also thank once again to our sponsors, Ramsey Health, and all of you who have attended and participated in this lectures of distinction. Just a couple of reminders. The first one is about your feedback. The feedback has appeared, the link, and also there will be a QR code right at the end. We are also going to just remind you of the next talk, Lectures of Distinction, which is next week on Wednesday, 6th of October, and it's on Achilles ruptures by one of my colleagues from Leicester, Mr. Mangwani. Hope you all have a very pleasant evening. Thank you very much once again, and bye-bye.
My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.